Hi, this is Dr. Mahadevan, and today we're going to be talking about the initial management of trauma patients. This is lecture 1 or part 1. So let's get started. What are our lecture objectives? We're going to review the initial assessment and resuscitation of victims of trauma, and specifically focusing on something called the primary survey, or the ABCDEs of trauma care. And then throughout the lectures, we're going to review potentially life-threatening conditions, how to recognize them, and how to treat them. So let's start with the ABCDEs of the primary survey. We are familiar with the ABCs, airway, breathing, and circulation, from advanced cardiac life support. However, in trauma care, we add a second C, D, and 2 E's. This airway, breathing, circulation. And then we want to do something called cervical spine control, making sure that we don't injure the patient's cervical spine through manipulation of their head or neck. We want to do a neurologic assessment or a disability assessment. So we do a disability assessment as well. And then we want to completely expose the patient to identify all of their injuries and ensure the environment in which we're caring for the patient is appropriate. So environmental control would include things such as removing the patient's clothing if it's wet, and keeping the patient warm. So the ABCDEs of the primary survey. And the primary survey philosophy is different than the way that we care for patients generally in medicine, and that is we are interested in identifying and treating life or limb-threatening injuries. And that comes first, and we defer the detailed patient history and evaluation for second injuries until later. So if we identify an injury, we treat it if we think it's life-threatening, and then we move on to the rest of our assessment. We don't continue assessing the patient and leave something potentially life or limb-threatening to be dealt with later. And an example of that would be something like this. You come upon a patient and you notice that there is an evisceration, and obviously that's very dramatic. However, that isn't going to kill the patient immediately. And so our focus is on those conditions, those potentially life-threatening conditions that affect the ABCs. We address them first and then later on address additional conditions such as this patient's evisceration. So what are these life-threatening conditions that we want to address during the ABCs? They include things such as loss of the patient's airway, respiratory failure, and then 4 important entities that can affect a patient's breathing. The first being tension pneumothorax, the second being massive hemothorax, something called flail chest, and then finally an open pneumothorax or sucking chest wound. In terms of circulation, the most common reason to have an issue with circulation is bleeding out or exsanguination. However, we also need to keep in mind patients may present with something called pericardial or cardiac tamponade. And then in terms of disability or the neurologic assessment, we're interested in whether the patient has an intracranial injury or a spinal cord injury with neurogenic shock. And then as I mentioned, the final part of the ABCs is E. And again, we want to expose the patient entirely so that we don't miss any injuries. And then we want to keep the environment warm. And we want to avoid hypothermia, which can negatively impact the patient. So we're going to start with A, or airway. And remember, no airway, no patient. Airway is the first priority. And when we're doing a focused assessment of a trauma patient in terms of their airway, there are 3 questions that we're going to ask. Is the airway patent? And when I say patent, I mean, is it open? Is it protected? And when I say protected, I mean protected from what? Protected potentially from aspirating the contents of the stomach or secretions in the pharynx. And then finally, is it at risk for obstruction? So our focused assessment on the airway is it open? Is it protected? Is at risk imminently for obstruction? So as part of that assessment, the first thing that we commonly do is ask the patient their name. what's your name? And if they speak, then that suggests that the airway is okay for that moment. We're also going to be listening for abnormal airway sounds such as snoring or stridor. And then we're going to use our eyes and look for things such as swelling or bleeding. If we have the opportunity, we're going to quickly open the patient's mouth and take a look in their oropharynx. And all the while, again, it's very important to make sure that you stabilize the cervical spine and inspect the neck to make sure that there's no penetrating injuries, swelling, or other issues. In terms of treatment, step one is always going to be to open the airway. And in this particular circumstance, the difference between opening the airway in a trauma patient and a medical patient is that we generally are always going to use the jaw thrust maneuver, and we're going to avoid the head tilt chin lift maneuver because potentially performing the head tilt chin lift could injure the patient's cervical spine. So in order to prevent that injury, we're going to use the jaw thrust maneuver preferentially. So again, protect the cervical spine, make sure that you don't flex, extend, or rotate the neck. It can happen inadvertently if you're not paying attention to the patient's neck. And one principle or adage in trauma care is that we always assume that the patient might have a spine injury, even if they don't have signs of a neurologic deficit or obvious evidence of a spine injury. We assume that the patient has a spine injury until we can exclude it. Step 3 in airway treatment is to remove any foreign bodies that might be within the airway and definitely suction any secretions, blood, or other fluids that may be in the patient's pharynx. And then we want to maintain an open airway. And there's two approaches. We can use the oropharyngeal airway or the nasopharyngeal airway. Keeping in mind in trauma patients, we want to avoid using the nasopharyngeal airway in any patient that has evidence of a basilar skull fracture. If the patient requires it, the next step in airway treatment would be endotracheal intubation. And in this particular case, we're going to place a endotracheal tube through the patient's vocal cords into their trachea and blow up the cuff in order to provide ventilation and airway protection, all the while maintaining cervical spine immobilization. Who needs endotracheal intubation? What victims or trauma victims need endotracheal intubation? First of all, if the patient is unable to maintain their airway or keep it open, that would be a patient that might require endotracheal intubation. If they can't protect their airway for whatever reason, they have a loss of consciousness or altered level of consciousness, and they're at risk for aspiration, that might be a patient who you intubate as well. And then finally, anybody with a closed head injury, generally a GCS or Glasgow Coma Scale score less than or equal to 8, is going to get intubated and assisted ventilation to protect them during their subsequent evaluation. Other patients that might require endotracheal intubation, obviously if you're not breathing or you're having respiratory failure, the inability to oxygenate and ventilate. And then finally, certain trauma victims may have impending airway compromise, and this would include patients who have penetrating injuries to their neck and might have an expanding hematoma, which at the moment isn't impacting their airway, but over time can grow and distort their airway. In those circumstances, you might intubate the patient early in order to protect their airway. Another patient that fits this category would be someone who is involved, has a thermal injury to their airway, so they're in a house fire or near very hot gases. They inhale them, they injure their airway, and then edema develops slowly over time and can close off their airway. So if you're suspecting a thermal injury, that would be another patient who you might intubate early. So again, penetrating injury or thermal injury. And when I say penetrating, specifically penetrating to the neck.